Hello and welcome back. Today we're going to be discussing COPD, bronchiectasis, and asthma, which are among the most common chronic respiratory conditions nurses encounter in both acute care and community settings. And as your book explains, chronic respiratory disorders are characterized by long-term impairment in ventilation or gas exchange that affects a person's ability to oxygenate tissues and eliminate carbon dioxide. So these conditions can significantly impact quality of life. And they're also major causes of morbidity and hospitalization. So throughout this lecture, we'll review the patho, risk factors, clinical manifestations, diagnostic testing, and then in class, we'll talk about pharmacologic management, priority nursing interventions, complications, more of that sort. So before we begin, let's review our learning objectives for today's class. So by the end of this lecture, you should be able to apply your respiratory assessment skills that you've learned and your clinical judgment to care for clients with chronic respiratory disorders, particularly the COPD, asthma, and bronchiectasis. So first, you'll be expected to differentiate normal and abnormal respiratory assessment findings. So we'll review what to look for during inspection, palpation, percussion, auscultation, and discuss how these findings help identify underlying disease processes. Second, we'll apply the nursing process and clinical judgment throughout the lecture. And so rather than just simply memorizing signs, symptoms, and medications, we're really going to focus on recognizing patient priorities, selecting appropriate nursing interventions, collaborating with our interprofessional team, monitoring for any changes, and then providing effective patient education. We'll also compare the major chronic respiratory disorders, discussing how their patho leads to the clinical manifestations you will see at the bedside. We'll examine common risk factors, diagnostic testings, and in class we'll talk about pharmacologic therapies and evidence-based nursing management strategies. Finally, we'll emphasize recognizing complications early. We'll discuss how to identify worsening respiratory status, acute exacerbations, respiratory failure, and other complications, as well as the nursing actions that can improve patient outcomes. So as you listen today, think beyond what is the disease and ask yourself, what is my priority as the nurse? Here's our agenda. So we'll do a quick overview of the respiratory system. We'll talk about COPD, then bronchiectasis, and finally asthma. So before we discuss specific chronic respiratory disorders, it's important to, again, review the anatomy and function of the respiratory system. So respiratory disorders are among some of the most common conditions encountered in healthcare and are a major cause of hospitalization and chronic illness. So the respiratory system, again, is divided into the upper and lower respiratory tracts, which work together to move air into the lungs and facilitate gas exchange. The upper respiratory tract includes the nose, paranasal sinuses, pharynx, tonsils, adenoids, larynx, and trachea. And these are structures that are helpful to filter, warm, and humidify inspired air, while also serving as the first line of defense against pathogens through mucus production and ciliary action. The lower respiratory tract consists of the trachea, bronchi, bronchioles, alveoli, lungs, pleura, and mediastinum. So as air moves deeper into the lungs, the bronchi branch into progressively smaller bronchioles that terminate in millions of alveoli, where oxygen diffuses into the bloodstream and carbon dioxide diffuses out to be exhaled. The primary functions of the respiratory system are, again, ventilation, which is the movement of air into and out of the lungs, gas exchange, which occurs across the alveolar capillary membrane, and oxygen transport to body tissues with the removal of carbon dioxide. So effective respiration depends on all of these processes working together. So as we move through COPD, bronchiectasis, and asthma, think about which part of the system is primarily affected and how those structural changes lead to the symptoms your patients experience. So let's start by talking about COPD, chronic obstructive pulmonary disease. So I want you to understand here what is happening inside of the lungs, because once you understand the patho, everything else, our assessment findings, medications, and nursing interventions are going to become much easier to understand. So what is COPD? This is a progressive chronic inflammatory lung disease. It's characterized by persistent airflow limitation that is not fully reversible. Unlike asthma, where airflow obstruction is usually reversible with bronchodilators, here the airway is damaged and it becomes permanent over time. So COPD is actually really used as an umbrella term that includes two disease processes, one being chronic bronchitis, which primarily affects the airways, and emphysema, which primarily affects the alveoli. So most patients have features of both conditions, although one may predominate the other. So the majority of COPD cases are caused by years of exposure to inhaled irritants, most commonly cigarette smoke, and these irritants trigger chronic inflammation throughout the lower airways. So with chronic inflammation, as the lungs are repeatedly exposed to smoke or pollutants, inflammatory cells migrate into the airways and release chemicals that damage lung tissue. And the body tries to repair itself, but because the exposure continues, the repair process becomes abnormal. In chronic bronchitis, the inflammation mainly affects the bronchi. The airway lining becomes swollen and thickened, goblet cells enlarge and produce excessive mucus. The cilia, which normally sweeps mucus upward, also become damaged and eventually stop functioning effectively. So now we have excessive mucus, narrowed airways, poor mucus clearance, and this is going to explain why patients develop that classic productive cough we see with chronic bronchitis. And then in emphysema, the inflammatory process destroys the alveolar walls. So normally millions of tiny alveoli provide a very large surface area where oxygen enters the blood and carbon dioxide leaves the body. And over time, those walls break down. Small alveoli merge into much larger air spaces. And this dramatically reduces the surface area available for gas exchange, and at the same time, the lungs lose their elastic recoil. So healthy lungs behave almost like a rubber band. So after inhalation, they naturally recoil, pushing air back out. But in emphysema, that elasticity is lost and air becomes trapped inside the lungs. So patients can still inhale reasonably well, but exhaling becomes really extremely difficult. And this explains why COPD is primarily considered an obstructive disease. Let's talk a little bit about air trapping. So because patients cannot completely exhale, each breath begins before the previous breath has finished. So air is accumulating inside of the lungs. This is called air trapping. And over years, hyperinflation develops. So their lungs become chronically overinflated. So their diaphragm gradually flattens. And since the diaphragm is now flattened instead of dome-shaped, it becomes much less effective during breathing. So this is one reason patients become short of breath, even with minimal activity. And then gas exchange. So eventually, because of airway obstruction and destruction of alveoli, we have less oxygen reaching the bloodstream. Carbon dioxide becomes harder to eliminate, and so this produces hypoxemia and sometimes hypercapnia in advanced disease, which causes increased work of breathing. And hopefully that patho makes sense. So let's talk about risk factors and look at what increases someone's risk for developing COPD. So cigarette smoking. This accounts for approximately 80 to 90% of COPD cases. Both active smoking and secondhand smoke increase risk. So the longer someone smokes, the greater the cumulative lung damage. There's also things like environmental exposure, so long-term exposure to occupational dust, chemical fumes, biomass fuels, air pollution. These can also contribute to chronic airway inflammation. Then we have an uncommon situation, alpha-1 antitrypsin deficiency. So this is an important genetic cause. So alpha-1 antitrypsin normally protects lung tissue from enzymes that break down proteins. So without enough of it, alveolar destruction occurs much earlier in life, even if they've never smoked before. So that could be another risk factor. And the other one is age. So COPD usually develops after many years of exposure, and most patients are diagnosed after the age of 40. Also, previous respiratory infections. So frequent respiratory infections during childhood or adulthood may accelerate lung damage. And then family history. Genetics also influence susceptibility. Some individuals are simply more vulnerable to lung injury from smoking than others. So now let's connect the pathophysiology to what we're actually observing during our assessment with our clinical manifestations. So let's start with chronic cough. So why do patients cough? So because mucus production is excessive, the cough is the body's attempt to clear those secretions. And we just talked about why that cough is occurring in the first place, especially for chronic bronchitis. Sputum production. So thick mucus accumulates because damaged cilia, it can't remove it effectively anymore. And so that's why we see increase in sputum production. And then we see dyspnea or shortness of breath. And this develops because they have narrowed airways. Remember, they have air trapping, hyperinflation, that destruction of alveoli, and that creates less surface area for gas exchange. All of these reduce oxygen delivery. So initially, in early stages, dyspnea will occur only with exertion, but eventually patients with severe or end-stage COPD will have shortness of breath at rest. Wheezing. Narrowed bronchi create turbulent airflow, so this produces wheezing, particularly during expiration. Fatigue. Patients expend tremendous energy just trying to breathe. So breathing that is effortless for healthy individuals becomes really physically exhausting for these patients. Weight loss, especially in emphysema. These patients are burning significant calories, again, just simply trying to breathe. Also, eating becomes really difficult because breathing takes priority, and it does take a lot of breathing to be able to chew food. So sometimes they just get too fatigued. Cyanosis, this is generally a late finding. It really indicates significant hypoxemia. So by the time cyanosis develops, gas exchange has become severely impaired. So now let's briefly discuss how COPD is diagnosed. So diagnosis always begins with a thorough history. We ask about smoking history, occupational exposure, chronic cough, sputum production, dyspnea, and exercise tolerance. And then physical assessment, so common findings like we just talked about, prolonged expiration, diminished breath sounds, wheezing, barrel chest, use of accessory muscles, pursed lip breathing. So the gold standard for diagnosing COPD is spirometry, which is a pulmonary function test that measures how much air a person can move in and out of their lungs, as well as how quickly they can exhale. So during the test, the patient takes the deepest breath possible and then exhales as hard and as fast as they can into a mouthpiece connected to the spirometer. And so the test is usually performed before and after administering a bronchodilator. And this allows providers to determine whether airflow obstruction improves significantly after medication. And there are key values here. There's two measurements that you should know. So we have forced expiratory volume in 1 second, FEV1. This measures how much air the patient can forcefully exhale during the first second of exhalation. And in healthy lungs, most of the air leaves the lungs quickly. In COPD, narrowed airways and loss of elastic recoil make it difficult to exhale rapidly, so the FEV1 is reduced. And then we have forced vital capacity. This is the total amount of air a person can forcefully exhale after taking a full breath. Even though patients with COPD may eventually exhale most of the air, it takes much longer because airflow is obstructed. So the value we focus on the most is FEV1 divided by FVC ratio. So in healthy adults, approximately 75 to 80% of the total air is exhaled during the first second. But in COPD, much less air can be expelled in the first second. So after using a bronchodilator, a ratio of less than 0.70 confirms persistent airflow obstruction and supports the diagnosis of COPD. I'm not asking you to know this. This is just like a nice to know kind of thing. But it's an important distinction as well from asthma, because in asthma, airflow obstruction is largely reversible after bronchodilator therapy. In COPD, the obstruction improves only minimally because permanent structural damage has occurred. So once COPD has been diagnosed, the FEV1 value is also used to stage the disease severity. So as the FEV1 declines, airflow obstruction becomes more severe, symptoms generally worsen, and the patient becomes more limited in their daily activities. So although you don't need to memorize every stage for the NCLEX, it's important to know that lower FEV1 values indicate more severe disease. We also have chest x-rays. So although chest x-rays cannot diagnose COPD themselves, they're really useful for evaluating the lungs and excluding other causes of respiratory symptoms. So in advanced COPD, a chest x-ray may show hyperinflation of the lungs, flattening of the diaphragm, increased anterior-posterior chest diameter, more horizontal ribs, sometimes larger lung fields because of that air trapping. So a chest x-ray is also important because patients with COPD frequently develop complications such as pneumonia or pneumothorax, which can also be identified using a chest x-ray. Arterial blood gases. So these are not routinely obtained for every patient with stable COPD, but become very important during moderate to severe exacerbations or when respiratory failure is suspected. ABGs tell us three important things: how well oxygen is moving into the blood, so that PaO2, how well carbon dioxide is being removed, so PaCO2, and whether the body's acid-base balance is normal, so the pH and the HCO3, the bicarb. So in advanced COPD, patients often do have a low PaO2, so hypoxemia, again, because damaged alveoli, why do I keep saying that, impair oxygen diffusion. They also have an elevated PaCO2, hypercapnia, even a little bit, because air trapping makes it difficult, again, to exhale that carbon dioxide. But over time, many patients develop this chronic respiratory acidosis, and so the kidneys try to compensate by retaining bicarb, and this renal compensation helps normalize the pH, even though the PaCO2 remains elevated. But think about how much work the kidneys have to do in order to do that over time. So keep that in mind. And then pulse oximetry. This is a quick, non-invasive way to continuously monitor oxygen saturation. It's going to provide us real-time information about how well hemoglobin is carrying oxygen. It is commonly used in both inpatient and outpatient settings. Pulse ox does have an important limitation. It does not measure carbon dioxide levels, though. So a patient with COPD may have a normal oxygen saturation, but still be retaining significant amounts of carbon dioxide. So that is why ABGs remain necessary when there is concern for worsening ventilation or respiratory failure. So now let's talk about bronchiectasis, which is another chronic respiratory disorder. Although it's not as common as COPD or asthma, it's important because patients often experience recurrent respiratory infections and chronic sputum production. So understanding the underlying patho here is going to help explain why these infections continue to occur despite treatment. So what is bronchiectasis? This is a chronic condition characterized by permanent dilation and destruction of the bronchi, and it's due to repeated inflammation and infection. So unlike asthma, where airway narrowing is reversible, or COPD, where airflow limitation develops gradually, bronchiectasis involves irreversible structural damage to the bronchial walls. So once the bronchi become damaged and stretched, they cannot return to their normal size. And the hallmark of bronchiectasis is poor mucus clearance, leading to repeated infections, ongoing inflammation, and progressive lung damage. So let's walk through the disease process step by step. So we have step one, which is initial injury. So bronchiectasis usually begins with some type of injury to the airway. This may be severe pneumonia, repeated respiratory infections, maybe aspiration, maybe someone has cystic fibrosis or an immune disorder. So regardless of the cause, inflammation develops within the bronchi. And then step two is chronic inflammation. So inflammatory cells release those enzymes that gradually damage the bronchial wall. The muscular layer and elastic tissue begin to break down, and over time the bronchi become permanently widened. And then step three is the loss of mucociliary clearance. So normally mucus traps bacteria and debris, and those tiny cilia move that mucus upward where it can be coughed out or swallowed. But in bronchiectasis, both the bronchial wall and the cilia are damaged. So as a result, mucus cannot be cleared effectively. So then we get mucus accumulation. So the widened bronchi become reservoirs where thick mucus collects. You want to think of this as like a large pipe where water no longer flows efficiently. So instead of clearing secretions, the mucus simply pools inside the airways. And then we get recurrent infections because that stagnant mucus becomes an excellent environment for bacteria, and patients are going to experience repeated respiratory infections. And so each infection then produces additional inflammation, and more inflammation causes further airway damage, which creates a vicious cycle of infection, inflammation, impaired clearance, and progressive airway destruction. And so that is bronchiectasis. So we have several risk factors or conditions that can damage the airways and lead to this, which I've already just kind of mentioned, but recurrent respiratory infections like pneumonia or severe bronchitis, cystic fibrosis, this is one of the most common causes in younger patients, immunodeficiency, so patients with primary or acquired immune deficiency have difficulty fighting infections, so might get repeated lung infections, which damage the bronchi. Aspiration, so any repeated aspiration of food, saliva, or gastric contents. This can cause chronic airway inflammation. Primary ciliary dyskinesia. So these patients are born with dysfunctional cilia. Even though mucus is produced normally, it cannot be effectively transported out of the lungs, and so that is a risk factor. Smoking. We know that smoking damages the cilia and it contributes to chronic airway inflammation, so that makes sense. And then we have other causes, connective tissue diseases, allergic conditions, congenital airway abnormalities, previous tuberculosis, tumors or foreign bodies, and airway obstruction from that. So now let's connect the patho to what we are going to be observing clinically with our clinical manifestations. So like I said, the hallmark symptom is a daily productive cough. So unlike many other respiratory diseases, patients often produce large amounts of thick purulent sputum, particularly in the morning after secretions have accumulated overnight. And the sputum may have a foul odor due to chronic bacterial colonization. Recurrent respiratory infections, again, because the bacteria remain trapped within the mucus. Patients develop frequent or recurrent pneumonia or bronchitis, which requires repeated antibiotic treatment. Shortness of breath, that makes sense with the mucus obstructing airflow. Fatigue from persistent infections and that increased work of breathing. Weight loss, chronic inflammation increases our metabolic demands, while repeated illnesses often reduce appetite. Cyanosis, so as the disease progresses and gas exchange worsens, hypoxemia may lead to cyanosis. Digital clubbing, this is a classic finding in advanced bronchiectasis, and I forgot to mention, but also in COPD, that chronic hypoxemia and prolonged inflammation. And let's end with diagnostics here. So the diagnosis combines imaging, pulmonary function testing, microbiology, and evaluation for underlying causes. So as always, we're going to start with a health history and physical exam. Important history includes chronic productive cough, daily sputum production, frequent pneumonias, childhood respiratory illnesses, cystic fibrosis, smoking, immune disorders. During our assessment, we are hearing for any coarse crackles, rhonchi, or wheezes. Again, that's going to be caused by those retained secretions. A high-resolution CT scan here is the gold standard for diagnosing bronchiectasis. So unlike a standard chest x-ray, a CT is going to provide us more detailed imaging of the bronchi. And so it typically shows permanently dilated bronchi, thickened bronchial walls, lack of normal airway tapering, mucus plugging. And so this is going to confirm the structural changes that define bronchiectasis. And then chest x-ray, these are less sensitive, but may show chronic infiltrates, areas of atelectasis, increased bronchial markings, hyperinflation in some patients, and they're often used to monitor disease or identify pneumonia during exacerbations. And then spirometry, this helps evaluate how well air moves through the lungs. So most patients are going to demonstrate an obstructive pattern, meaning airflow is going to be reduced because, again, that mucus and damaged airway narrow the lumen. Sputum culture also may be helpful here because infections are so common. Sputum cultures are going to be extremely important because they can identify the specific bacteria causing the infection and help us choose the most effective antibiotic. Well, not us, but the provider. And then blood tests are going to help determine whether an underlying condition has contributed. So maybe getting a complete blood count to look at inflammatory markers, immunoglobulin levels for immune deficiencies, maybe even testing for cystic fibrosis or the alpha-1 antitrypsin deficiency. So now let's discuss asthma. And like COPD, this is an obstructive lung disease. But there is one major difference I want you to remember. So the airway obstruction in asthma is usually reversible. So during an asthma attack, the airways narrow significantly, but with appropriate treatment or sometimes spontaneously, they can return to nearly normal function. So asthma is a chronic inflammatory disease of the airways. It's characterized by airway hyperresponsiveness, meaning the bronchi overreact to triggers that wouldn't normally affect someone without asthma. So the patho here is an exposure to a trigger. So asthma begins when a susceptible person is exposed to a trigger, and these triggers vary from person to person, may include allergens, viral infections, exercise, stress, cold air, smoke, strong odors, or sometimes occupational exposures. So this trigger activates immune cells within the airway, particularly our mast cells, eosinophils, and T lymphocytes. And those are going to release inflammatory mediators such as histamine and leukotrienes. And these chemicals initiate the inflammatory response. And then we get inflammation. And that inflammation causes the lining of the bronchi to become swollen or edematous. And blood vessels within the airway dilate, become more permeable, which allow fluid to move into the airway tissue. So the swelling narrows the airways. At the same time, the smooth muscle that surrounds the bronchi are suddenly constricting. So this process is called bronchoconstriction or bronchospasm, and we want to think of that as a flexible tube surrounded by muscle, and during an asthma attack, that muscle squeezes the tube, making the opening much smaller. Inflammation stimulates mucus production from our goblet cells. And so thick mucus accumulates inside the already narrowed airway. So now the airway is narrowed in 3 different ways. We have inflammation and edema, smooth muscle contraction, and excess mucus production. So that's all going to not allow that patient to breathe. We get airflow obstruction. So patients have the greatest difficulty exhaling because expiration is largely passive. So during exhalation, the narrowed airways become even smaller, making it difficult to move air out of the lungs. So this explains why wheezing is typically heard during expiration. But one of the defining features of asthma is that the obstruction is usually reversible. So once inflammation and bronchospasm improve, airflow returns towards normal. And this is the major difference between asthma and COPD. It's important to remember that poorly controlled asthma can eventually lead to airway remodeling. So chronic inflammation causes structural changes in the airway, including thickening of the basement membrane, increased smooth muscle mass, and enlargement of mucous glands. So these changes can make asthma progressively less reversible over time, which is one reason why controlling inflammation early is going to be so important. Let's talk about risk factors and causes. So several factors increase a person's likelihood of developing asthma. So allergens. Common allergens include dust mites, pollen, mold, pet dander, and these are triggered by the IgE-mediated immune responses in susceptible individuals. We also have irritants, so smoke, air pollution, perfumes, chemical fumes, and strong odors may also trigger bronchospasm, even in the absence of allergens. Respiratory infections, so viral respiratory infections are among the most common triggers of asthma exacerbations, particularly in children. And then genetics. Asthma frequently runs in families. Multiple genes contribute to airway hyperresponsiveness and immune responses, so that is why. And then we also have exercise-induced bronchoconstriction, which occurs because rapid breathing causes cooling and drying of the airway, which then triggers bronchospasm. Obesity, this is associated with increased airway inflammation and reduced lung expansion, increasing asthma risk and symptom severity. So now let's talk about clinical manifestations. You're definitely going to hear some wheezing, and wheezing develops because air is forced through narrowed bronchi. It's usually heard during expiration. Interestingly, if a patient with severe asthma suddenly stops wheezing and breath sounds become absent, that's actually really dangerous because it may indicate no airflow. We call that a silent chest, and that is a medical emergency. We'll talk about that more in class. Dyspnea, patients experience shortness of breath, especially when they have an exacerbation because airway narrowing increases the work required to move air. Cough, many patients have a chronic cough, particularly at night or early in the morning, and this occurs because airway inflammation tends to worsen overnight due to normal circadian changes in inflammatory mediators. And actually, a dry cough is an early indicator that a patient may go into an asthma attack. So they could start with a trigger, start a dry cough, and then develop wheezing. We see other things. The patient might feel chest tightness, often describing a feeling of pressure, and that is resulting from bronchospasm. And then they might end up becoming fatigued. So the increased work of breathing requires significantly more energy. So during prolonged exacerbations, respiratory muscles will eventually fatigue, and the patient will stop trying to breathe. And then difficulty exhaling. Patients can usually inhale reasonably well. The greatest difficulty occurs during expiration because the narrowed airways collapse even further as air leaves the lungs. Finally, diagnostics, which again is going to combine history, pulmonary function testing, and occasionally additional testing. So we have a health history and physical. We're asking about recurrent wheezing, nighttime cough, known triggers, any seasonal symptoms, family history, any previous hospitalizations or intubations, medication use. And during our assessment, we're looking at the lungs, of course, so hearing for any wheezing. Spirometry is the gold standard. This is a primary diagnostic test for asthma, and so patients are performing forced exhalation before and after receiving a bronchodilator. During an asthma exacerbation, the forced expiratory vital capacity in 1 second decreases because narrowed airways are going to limit that airflow. The key finding is significant improvement after bronchodilator administration here. Peak expiratory flow, this measures the maximum speed of exhalation. So unlike spirometry, it can be performed at home with a handheld peak flow meter. So patients often monitor their peak flow daily, and this is just to detect worsening airway obstruction before symptoms become severe. Declining peak flow values may indicate the need for any adjustments to their medication regimen. It might also tell them to just go to the emergency department but we call that the asthma action plan. Bronchoprovocation testing. I'm so sorry. Sometimes patients have asthma symptoms, but the spirometry is normal. And in these situations, a bronchoprovocation test, such as the methacholine challenge, may be performed. And this intentionally causes mild bronchoconstriction. So patients with asthma are much more sensitive to this medication, and it may demonstrate airway narrowing at much lower doses than healthy individuals. And because it intentionally induces bronchospasm, this test is performed under close medical supervision. And finally, allergy testing. Since many patients have allergic asthma, skin testing or serum IgE testing may help identify triggers. So knowing the patient's triggers is going to allow for more effective environmental control and long-term management. And that was it for today. So I will see you in class and we'll talk more about the management, the medications, the complications, and the nursing interventions and nursing considerations. I'll see you then.